Please, Professor Saturno, you are the only one missing with the presentation, and we are already very, very curious to hear more about the pilot project in Spain.
Okay, good morning or good afternoon. I'm sorry about this delay, completely unintended. I don't like this situation of everybody looking at what I'm supposed to say, but that has been the situation. So I'll try to be brief. I have been informed briefly about what has happened so far in the meeting. I know that there has not been any discussion, so I guess that after my presentation, we will start with the interesting part of the meeting, which is the discussion of the document and the indicators and what to do after this meeting. So, actually, this is the third time that I'm presenting this project in this environment. It's just that every year we have something more. But this time, let me see, even though the outline is more or less similar, I think I will put more emphasis on the method part, because after the discussions that we have had in the group, I guess that we need some kind of common language to understand each other. Things so simple like what is an indicator, what is monitoring, what is all these type of things, because I realized that not everybody is in the same pace, on the same method. So I will stress the methodological part. And I will start with the introduction, stressing that we are talking about tools for monitoring quality. And what is the meaning of this? The starting point is to know what we should do, what is called quality planning or design, practice guidelines, and all these type of tools telling us what to do. This is planning quality. But then we have to measure, to monitor if we are doing what it has been planned, what is good. In this case, good practices. So we are trying to implement, and I hope I can use this, yeah. A project where we are trying to find tools to monitor quality. And I think this is the first message, which is important. We want to be able to assess the level of quality in pain, chronic pain management. We want to identify problems that should be either further studied or improved, or both. And we want to have tools to control changes. For doing that, we try to build indicators. And indicators are measurement tools, are tools that can be used for all these type of things. And here I want to stress a difference that I think is important. An indicator is not a recommendation. Recommendation comes first. Evidence-based recommendation that maybe has been studied or has been not studied, the group of experts thinks that is good for the system or for the clinical practice. This is something different from an indicator. An indicator is a tool to measure if you are implementing a good recommendation. I'm sorry, I'm sure that many of you know about all these things, but in the discussion that we have had, I realized that not everybody has the same language, so this is our language. The last thing is what is a good indicator. It's a tool for monitoring quality, but for an indicator to be good, we may have a big list of things, but the three more important things are these. First, it should be valid. Valid means evidence-based. It's not something that I think, I believe, or something like that. It has been studied, there is some research, and you know that if you implement what the indicator is measuring, you are doing a good thing. The second is reliable, meaning that everybody will interpret and use the indicator in the same way. There is no words or way of interpreting the indicator that will differ in the results. But the thing is that the reliability, again, should be empirically tested. The validity should be evidence-based, meaning that you need some research previous to the recommendation on which you will base the indicator. And then reliability should be also empirically demonstrated. And then the last thing, of course, is should be useful for monitoring, for doing this. And this can be applied at different levels in the health system, in a center, in a region, nation, in Europe, whatever level, it doesn't matter. Whatever level you are using it, it should be useful for control changes, for identify problems, and to assess the levels. So this is too simple, I know, but I feel I have to tell it because sometimes we don't understand each other because for us, or for some people, indicator is something different and the way of building them is different and so that. So that was the introduction, the terminology introduction. Now coming back to the project itself. The objectives was to build a set of tools, a set of indicators to measure the level of quality and to identify problems in the health system based on the evidence. The indicators will never provide evidence. They should be based on evidence, but it's not something that will tell you what is the evidence. And then also initially we wanted to cover the whole set of activities, clinical activities, assessment, initial treatment, prevention, and control. But let me tell you also a few words of what is the meaning of this, because again, from the discussion that we have had, I realized that there are many different approaches to this. Unfortunately, there is not a single way of grading the evidence and the strength of the recommendation. There are many. So for our project, we have to look at all of them because different guidelines were used as a different grading system. Some guidelines, they don't use even no system. So we try to harmonize the main system that are out there and build a system that could be used to grade the evidence from all the guidelines and articles and references that we have used. These are the four that we tried to harmonize, and this is the system that we eventually have been using. All of them have in common the following. All the system, the first level of evidence, and when the research, the study, comes from randomized controlled trials, all of them. Then they proceed and they do different things. In general, when you have several randomized controlled trials with meta-analysis, it's the highest level because it's supposed that no one other study will provide a different type of evidence. But there are other times where just a single, very well-designed randomized control trial, for them is enough evidence. So you can use different levels of the first level of evidence, which is the A. Then there are the observational studies, which are the level B, with different types. Then, of course, there are studies without conclusions. And then the lower level of evidence is no good studies or yes consensus. I think that this is good, but this has no any study supporting it. For our project, we try to use mainly recommendations of this level of evidence. Sometimes also this one, and only occasionally, I think it's only one, we use the consensus for one single indicator in relation to cancer pain. But in general, we were basing our indicators on evidence level A or B1. If you don't do that, then what are you measuring? The evidence is the validity, is the first of the characteristic of the indicator. The same happened with the strength of the recommendation. The evidence is related to the quality of the study, and the strength of the recommendation is related to comparing the benefits and the potential adverse effects. Again, the first level, type A, is when there is significantly more benefits than adverse effect. Of course, if there is no adverse effect at all and everything is benefit, that's the best situation, but it is very difficult to find. This is practically the same, but with no great significant meaning. Here there is no recommendation because you cannot show that the benefits are better than the adverse effect. Then is when you know that there are more adverse effects than benefits, and then you should not do that. And then this type is the evidence, but you cannot decide. We, for the indicators, try to use a recommendation with this level, or this level of strength of recommendation. Something that should be done, that you may do, or there is evidence that you should not do. Okay? So, again, I'm sorry for so long introduction, but I think it's needed for the discussion. Because, as I told you already, I think an indicator is not a recommendation. A recommendation is before you build the indicator, and the recommendation may be good or bad in relation to the evidence or the strength of evidence of that, the strength of the recommendation. Now, briefly, the methods. I will be briefly because I explained this in the last presentation last year. We were following all these phases. First, the classification of pain, then the review, systematization of the evidence, existing quality indicators, which were very few, the indicators for the gaps, then pilot testing, measurement methods, and eventually the last step that was not done last year when I made the presentation was the prioritization, whatever, by experts. And I insist that this is not giving any validity or extracting, withdrawing validity to the indicator. It's just that in a given context, maybe they are less important for whatever reasons, because it's not a priority of the system, because the prevalence is less, because you cannot measure it, for whatever reason. I don't know exactly what is in the mind of the expert when they prioritize, but this is something different, that the indicator being valid, reliable, and useful. Maybe this is more related to the usefulness in a given context. I will give you some results that I didn't give last year. But before, because I just given you some examples, I'd like to remind you that the full report is available in Spanish and in English. The English report, the English version, I distributed a week ago, I think, because I think that everybody here has it. In my opinion, probably it would have been good to have the report before the discussions, but eventually, because some of the members of the expert group told me to have it, I distribute them. You can get them from the SIP platform, from me, from the Grünenthal, from many places. So these are the 3 types of pain that we eventually classified with different characteristics, chronic malignant, chronic non-malignant, which is the more difficult. More difficult because there are many different conditions in this type of pain, and the evidence is relatively more confusing. There are more things that has to be researched. These are the total number of indicators that we built: 22 for chronic malignant, 46 for chronic non-malignant, and 54 for the acute pain. I will focus in the few minutes that I'm presenting now on the chronic non-malignant pain indicators. Initially, there were 46. Of these that could be measured in at least one facility, we got 32. And eventually, we proposed a set of 32 that more or less are the same that we, in the pilot test, found that could be measured in at least one facility. And it doesn't mean that the other are not good indicators. It's just that in our context, the information system will not allow to measure them. But maybe in other contexts, they can be measured. That's why, at the end, I will tell you what is my proposal. Now, the last part of the project was to send the set of indicators to the regions, to the autonomous communities, for the ratings. It's the same process that has been used in the expert group for the European document. So here you have the region where they have been rated, the indicators. And these are the results of the ratings. If we focus, because this is the theme of the meeting, on chronic non-malignant pain, the numbers that you see in brackets are these indicators that were not feasible of measurement. So I like to use this to illustrate that it's not the same, the feasibility of measurement, that the interest that an indicator may have. They rate very high, 28, but 7 of these, in our context, it was not feasible, the measurement. I'll give you some little examples, because it's curious. This is all the 32 indicators, the one getting the highest rate, the treatment of chronic post-surgical pain, voted or rated the indicator. These two people, they gave also the highest rate. So what is the meaning of this? What can we conclude from that? Maybe for the other 8 countries, this is not a big problem. But it doesn't mean that it's not a good indicator. I understand that maybe in the majority of countries, this is not a problem for managing chronic pain, so they don't want to have an indicator on that. That's okay. But even in this group, the 2 people who rated this indicator, they gave the highest rate. I don't know who were. Now I give you some actual results. Just a few examples. Because it's a pity we have so many data and numbers that not to give any. And I'm using two sources for the data. One is the pilot project, and the other that you know already because you have been, this has been a presentation about the Adelphi surveys before. But the presentation one is in relation to the burden of disease, but I asked them to also try to look at the compliance of the indicators in the database. It's not the same methodology because in their database is the compliance according to what the physician thinks is happening. It's not the same. But with this limitation, we can have some results by country. So let me go. This is the one that I told you. It's funny that in our pilot project it has this. In taking into account all the surveys from Adelphi, in Spain is the only country where there is something done with chronic surgical pain. All the other countries, no one physician in the survey say that they are treating correctly this type of pain. So that is coherent. I mean, it's consistent with the fact that the expert has not rated this indicator high. For them, apparently, it's not important. Now, another example, typical example is this. Treatment for trigeminal neuralgia. This is the result we got in our project, and these are the results from the different countries. There is some variability, Italy a little less, but in general it's around the thing that we got in our project. Now, these examples around here, I want to use them for one of the things that we have found, is that in general, pharmacological treatments are more implemented than other type of treatments. Look at this. This is the treatment for fibromyalgia with antidepressants. This is what we got in our pilot project, and this is the figures from the surveys from Adelphi. But for this indicator, this is the figure, which is much, much less. And there are no figures in the, so far. I asked them to look at it, but I haven't got the figures yet. And the same for the therapeutic exercise for unspecific low back pain, which is much less when you look at the pharmacological treatment for the same condition, the same type of patient. So this is the situation. The situation is a big room for improvement, and this room for improvement is much more when it's not pharmacological treatment. And some of the conditions at the European level, they are not considered or they are not well treated. This is one example, but there are others. If the last example is a general indicator, I'm bringing it because it's related to the elderly people, to people over 65 years old. You all know that elderly people and children, they are special. You have to adjust medication. There are some medications that are not good for them and all that. And this is the results of this indicator in our pilot project, and this is the results in the European countries. Again, Italy is the one with the less compliance. Now the concluding remarks. First, I insist in the fact that we have offered is a menu of indicators. I'm not telling you that you have to use all of them. For a given context, for Europe, for a country, for a facility, you may select what type of condition, what type of indicator is more important for you. What I can tell you is that we make a big effort to translate into measurement tools the existing evidence. So you can choose. The prioritization is okay, but I don't think that is the first or second step. It's the last one. First, you may have good tools, good indicators, and then you prioritize. Also, I would like to tell you that because it has been so interesting, and now I have 3 doctoral students working on this, and they are updating the evidence so that the new things could be incorporated to the set of indicators, because we have to do this. I mean, no indicator is there forever. Some of them they are, but some of them has to be modified. I told you already there is a big room for improvement, so it's a good opportunity to try to do something for that. And the last thing, of course, is to thank you for this opportunity. There are many people if I mention everybody, it will be too much. But this opportunity of sharing all this with so many people, so many countries, in this forum, I think is something to be very happy about and to be very grateful. And of course, the people who have been working in the project. I haven't not mentioned them so far, but there were many people working for trying to get this set of indicators that you know or you can have now. So that's it. I guess that now you can ask questions, or maybe we go to a discussion. I don't know. I mean, you know, I came directly from the airport, and I don't know what is the way you are organizing the meeting.
So first of all, thank you for this presentation we were all waiting for. And what you have shown us is how everything started. It's the starting point also of our discussion. It has been the starting point also of the beforehand preparation of this meeting. We should have a few very urgent questions, and we will have also time. Yes, I think so. Yeah.